Good afternoon, and thank you for participating in this webinar that is titled Use of Coaxial Implants by Dr. Yuen. My name is Daniel Sarango, and I'm the technical support manager here at Southern Implants, and I would like to introduce you to Dr. Yuen. He's in private practice in Sydney and focused mainly in oral implantology. He is involved with both surgical and restorative phases, and he's a lecturer at the University of Sydney, teaching both graduate and undergraduate levels. He has been working with coaxials for about 6 years, and he has placed 1,100 implants so far. And so here is Dr. Yuen. So, by the way, if you guys have any questions, I will ask you to ask him at the end of the meeting so he can finish with his presentation. I will mute the background noise. So if you have any questions that need to be answered right away, then raise the hand and I will unmute you. Okay? Thank you so much. And here's Dr. Ken Yuen.
Okay, thank you very much. Is my voice okay? Okay,
yes,
I'm sure it is. Great.
It is very, very
good. Fantastic. So welcome, everyone. I wanted to present a very long presentation for an hour. Unfortunately, I tried to shorten it as much as I could, but there are a lot of things in there that I thought you guys might be interested. I've been placing coaxial implants now for the last 6 years, as the person who introduced me has said. And for the last 6 years, we've had very, very good success rates. You know, we've done about 1,100 coaxial implants now, and we've only had 3 that's failed, and I'll talk about them a little bit later. So these are very, very successful implants, and it's a big part of my practice these days. And I'm finding more and more uses for these coaxial implants. And just to let you know a little bit about myself, I'm from Sydney, so there's a picture of my hometown there. But I always look forward to meeting some of you guys, and I met Chris and Sonia a couple months ago, and I think I'm going to meet a couple more of you when I attend the South American Southern Implant Conference. So let's get straight into it. Now, as you know, oral implants are very important these days in treatment planning. You know, patients come to see us because they expect results in terms of a cosmetic and an aesthetic point of view, and also a functional point of view. Now, we know that functionally they work. But what we do need to also remember is that patients come and see us because they want final teeth. Now, this case here, this girl, a young girl, who's had some Maryland bridges placed, and you know what? The Maryland bridges are actually quite aesthetically okay. You know, the porcelain is chipping and wearing a little bit, but cosmetically speaking, both the soft tissue and hard tissue looks perfectly fine. Now, one of the things that we want to do with a case like this is we want to provide a restoration that will satisfy her aesthetic demands. She's got a high lip line, and we want to make something that is even better, or just the same as those nice Maryland bridges that have been placed some 7 or 8 years prior to this. So, you know, when we end up with an aesthetic case like this, we need to think about all the biology that we've learned over the years. We need to think about the fact that we're going to be placing these implants, especially in young patients, and they're going to have to last for life. And so this type of treatment, I would like to term a prosthetically driven treatment. Okay, as opposed to what used to happen was more surgically driven treatment. So, you know, when we're looking at a close-up of this case, you can see the 2 lateral incisors there, beautiful soft tissue, hard tissue is good, the actual prosthesis is reasonable. So we need to consider a few different factors here. We need to think about whether we should have a surgically driven treatment plan, or should the treatment be prosthodontically driven? And what I like to talk about today is that I think there's a compromise for both. I think we can satisfy the surgical needs, and I think we can satisfy the prosthodontic needs simply by changing our thinking about the type of implant or the actual design of the implant that we use. So, back in the days when Bronnemark, of course, did his implants with his co-workers, you can see here there are implants in the embrasure areas. There are implants with screw access that's coming through the buccal surfaces of teeth. And I think that in this day and age, if we were to do treatment like this, first of all, we're going to be behind in time. And second of all, patients expect more than this. And quite often, we're demanded to provide treatment that's better than this. You know, these days, we want to have embrasures that we can clean. We want to have screw access, if possible. And we'll talk about the screw access in just a sec. Now, I just wanted to let you guys know that, you know, we're not doing anything new here. We're still using osseointegration, and it's stuff that we've done for a long time. Now, this is a case that I had done a long time ago, and really, we didn't use coaxial implant in this case. It was a cement-on type of situation, and we can get nice results there. There's no doubt about that. The reasons why we get nice results, of course, is because we've observed Mother Nature, and we've observed that biology is the most important factor here. However, even though that's a key factor, having a cement-on restoration is not always going to be ideal. Why is that? Well, because we've got a number of factors that we need to consider. And I'll just quickly go through this section here where I like to compare cement retained versus screw retained restorations. So first of all, a restoration, especially on implants, can suffer from veneering fracture. So the most common one, of course, is porcelain fracture. And in the case like this, you can see that this is upper full arch implant supported case. And luckily, this case was screw retained. And because it was screw retained, we can easily take it off, send it back to the laboratory for repairs. Another example, this is a case with a young girl with a central incisor that was replaced by an implant by me. She came back about a year later, and she had fractured the incisal corner. And luckily, this was a screw retain restoration because all I did was I unscrewed the restoration. She had actually kept the fractured piece. All I did was put a little bit of low-fusing porcelain powder between the two pieces, put it back into the furnace, and the two pieces fused back together. So no new restoration needed. It was merely the old restoration that I've been able to literally fuse back on. And when you look at the literature out there, Peterson did a very nice review on complications, and he found that there were something like 38.7% complication with implant-supported prostheses in a 5-year period. The complication was mostly from, guess what, ceramic fracture. This is comparing to normal fixed bridges or free-end saddle bridges where the failure rate or the chipping rate is much lower. It's less than half that of implant-supported prostheses. So fractures are an important thing. Now, these pictures are from my friend Dale Howes, Professor Dale Howes from South Africa, and you can see this is one of his cases. Patient's obviously fractured some veneering material there, and he's tried to remove it because it's cement retained. And some 2 hours later, he's managed to remove all the prostheses, but it took all 2 hours plus all those burrs, the time, the effort. And really, I don't think that this day and age, we wouldn't want to do anything like this because we have better ways of restoring our cases. So another factor about cement retained versus screw retained is the maintenance. We know that when Yemt did this prospective study on single tooth implants, the 1-year prospective study results shows that there were 26% screw loosening. He published this in 1991. 26% after 1 year of loading, and that's a huge amount. And if it was a cement-on restoration, we couldn't tighten the screw up. So in the case like this, where it's a screw-retained restoration, all I needed to do was to remove the composite that's on the palatal side of the tooth and just take it out, clean it, pop it back in, and tighten the abutment screw. What about a case like this? The first premolar there, this case came back about 5 years later. I saw this case a couple of weeks ago. The referral dentist had sent this patient back to me because of that inflammation around the mucosa there. Now, I don't know whether any of you have seen this, but it happens very, very rarely. And luckily, because it was a screw-retained prosthesis, I managed to remove it. And when you look at it, that there on the abutment fixture interface, that there is actually calculus. That's hard calculus. So literally, I took it off, scaled it, and then put it back into the patient's mouth. It was not possible to scale it without taking it out because it didn't show on a radiograph, and the dentist just couldn't detect there to be any calculus there. So luckily, as you can see here, I've been very lucky to have a screw retained restoration that I could remove. Okay, so the next thing that's a problem with cement retained prostheses is that you can get residual cement. And when we talk about residual cement, that's to do with cement that's been left there after the placement of the restoration. Color and shape is also another problem. Now, no matter how hard we try, we can take photos, we can even send the patient to the technician. Sometimes the color and shape isn't exactly right, and patients may come back here to say that they're not happy with the restoration. So this patient here had the restoration. About a week later, she came back and said, look, she's happy with the shape because she had a little diastema there before, which we closed up, but she's not happy with the color. And being a central incisor, color is everything, as you know. So luckily, because of the screw retained restoration, what we've done is we've just removed the restoration, send it back to the technician, or if you have a porcelain furnace in your office, you can actually restain the restoration so that it would be acceptable for the patient. Okay, now gingival contouring. I think this is a very big factor here because if you have a stock abutment here like this is an adaptable abutment, and we cemented our restoration over the top. Well, first of all, we've spoken about the residual cement that can be caused by a restoration like this. Plus, you get a lot of blanching on your gingiva, and when you get the blanching there, you know that there's a possibility the restoration may not be seating all the way up there. So what do we do in cases like this? Well, in the past, what I've done to eliminate the problem is I've used temporary crowns, and these temporary crowns have been used to shape the gingiva, because some of the issues are, well, we need to remove the cement, as I said before. If we need to remove the cement, we need to know where the anticipated gingival margins are going to be. And in order to predict where the margins are, we need to know what the transmucosal contours are. And once the transmucosal contours have been established, how are tissues going to react? Is it going to recede? Is it going to recede apically, or is it actually going to develop like in the proximal areas? In other words, it's actually going to increase in size, and we don't know that. So therefore, as I said, we're in this case with a temporary restoration there, a temporary crown, and the temporary crown have, as you can see, developed that gingival contour. And because we've developed that gingival contour, we've been able to make a custom healing, custom abutment here in zirconia in this case. And with that abutment, you can see we can now accurately predict what the transmucosal contours are. We can now predict where the gingival margin is going to be, so we can design our cement line. And so there's our cement-on restoration. And I believe that this is the only way we can get a cement-on restoration where the contours are going to be predictable. So therefore, with a situation like this, we need to fabricate a temporary restoration there. And we need to fabricate maybe a second temporary restoration if we need to remove the first temporary restoration for the technicians to copy. We have to use ceramic abutments, and we need to factor in the fact that there may be some recession in the future. You know, all these problems can be corrected, of course, or avoided simply by having a screw-retained prosthesis. This is a temporary crown, and as you can see, the angulation allows for screw retention on the cingulum. However, the problem is sometimes the bone and soft tissue doesn't allow this restoration to be screw retained, because it means that the fixture will be coming through the buccal bone there. Now, another factor is post-procedural treatment. In a case like this, we've got a patient who came in and from the periodontist, actually, periodontist that placed the implant. I was expected to do the restoration. And then, a year later, the periodontist decided to extract some of the other teeth and place more implants there. Now, you can probably see there's a little bit of pus even on the left-hand side, on the patient's left. And, you know, it was a real mess. And in order to, for me to make a new restoration, I had to remove the old one. And luckily, because I had screw retained this restoration, I've been able to remove the old restoration fairly easily. When it comes to multiple implant cases, we need to think about path of insertion with cement-on prosthesis. Here's a case here. Every abutment there had to be engaging on the anti-rotational feature of the implant, plus they had to be milled so that they had all the same path of insertion. And because they have to engage the actual implant, we actually have to make a jig that allows us to locate where the implant in a 360-degree rotational fashion that they have to be pointing in exactly the right way according to what the technicians have done. Okay, so also teeth move, of course, and implants don't. So in a case where the restoration have been there for a few years, you might find mesial drifting of the other teeth, and you'll get a food trap there. Again, with a cement-on restoration, there's nothing you can do about it. But with a screw-retained restoration, we can add a little bit more porcelain to actually block that food trap there. And mesial drifting happens to most of our patients, and some faster than the others. If we were to place an implant, say in the lower molar in this case, what we'll find is we're going to find drifting on the anterior teeth, whereas the posterior teeth aren't allowed to drift. So the posterior contact will always be tight, but the mesial contact might open up as time goes on. So, do we want to make these prostheses serviceable? And of course the answer is yes, because we want to be able to retrieve these prostheses if we had it in our mouth. And if we had to remove these cement-on prostheses, we would have to remake the actual prostheses. So should we be charging the patient for the new prosthesis? One of the issues that we have in Australia is that if there is an issue, if something has happened to a restoration and the patient's had it for, say, 2, 3, 5 years, should we be charging the patient? Because legally, they may challenge us. And in order to avoid us getting into legal troubles, we may have to remake these prostheses for free. And do we really want to spend all that time cutting off a cementon prosthesis if something has gone wrong? So, therefore, I think we need to laterally think about things. Remember, the mother of all invention is necessity. And what I mean, well, in terms of necessity, any of you recognize this gentleman here? This guy is Swedish. His name is Gösta Larsson, and he had lost all his teeth because of a motor vehicle accident. And luckily for him, his necessity was fulfilled by this gentleman here, P.I. Brånemark, who placed his very first implant into Gösta Larsson in the posterior mandible, and here's the radiograph of the very, very first implant sitting on top of that inferior dental canal there. Now, if it wasn't for the fact that this is needed, the invention never would have come up. So, what do we need? Well, in a lot of our patients, we have a premaxilla which is very, very resorbed. So this is an example here. Premaxilla, huge buccal concavity. We need an implant that would actually go nicely in there and integrate and provide us with a restoration. Now, we've just spoken about screw retained versus cement retained. Preferably, in a case like this, I would like to screw retain the restoration. So, now, so this is a clinical case. You can see we've actually drilled the holes there. And if you notice very carefully, in the more apical you go, the more apparent the concavity is, the more pronounced the ditch is in the bone. And if we wanted to have a screw retain restoration, that implant would go easily out through the buccal bone there and into the soft tissue. In the past, we've tried to overcome both problems by placing the implant where it's going to be accessible by where it's going to go through the actual bone, and we want it to be screw retained. So what we did was we cross-pinned these restorations, and it was a lot of work. And you require a secondary screw there, and really, when it comes down to it, should we really go through all that trouble? And how hard is that to handle in the mouth? Because in order to put a cross pin there, what I've had to do is I've had to use a screwdriver on the palatal side or the lingual side. And quite often these screwdrivers can easily be dropped in the patient's mouth because it's such an awkward angle. So, after that long-winded discussion, we've now come to the coaxial implant. And this is what we want to see. This is an implant that's got a 12-degree angle on it, and it runs with 24 degrees as well. Because the reason why we need this is because, well, traditionally we've had an implant that's placed on the long axis of the teeth, and using this implant we can now place restoration. But the restoration, because the implant is on the long axis of the tooth, has a screw access through the incisal edge. So if we want a screw retain restoration, we would have to tilt the implant back towards the palatal or lingual side. And if we were to do that, what we'll get is we get a restoration that's got a pronounced buccal bulge there in order to create our emergence profile. And quite often, this can result in ridge lapping. So you might say, well, in order to avoid ridge lapping, we can make the fixture deeper. But when we make the fixture deeper, of course, we will encounter a very deep fixture that's going to be harder to clean, bigger niche for bacteria to grow in. So you might say, well, okay, well, what about using an angulated abutment? An angulated abutment allows us to correct the angulation plus give us a screw access. Now, the problem with these is that they've all got very, very large buccal shoulders, and because they're in titanium, they can often show through the gingiva. And you can see here, this case is from Professor Howes again. You can see the buccal shoulder there showing through, and cosmetically, it's a nightmare to try and handle. And all this because we want screw retain restorations. So, what we're talking about now is we want a screw retain restoration, but also what we've spoken about is the fact that quite often we get a buccal concavity there. So in a case like this, what do we do? Well, let me show you, first of all, what other people do. These are pictures from Professor Danny Boozer, and Danny Boozer is from Switzerland, and this is what he does. In order to get a screw retain restoration, he would place the implant, and he would deliberately perforate the buccal bone there. And then after perforating the buccal bone deliberately, he would then place a layer of autogenous bone, a layer of bile-os, a layer of bile guide. After all that work, after having placed hundreds of dollars of bile-os and bile guide, he's now created a screw-retained implant in that patient. Now, another way of grafting in this case is by the use of block grafts. This is done pre-placing the implant so that it's had enough time to integrate before the implant is placed. But we don't want to do all that. What we want to avoid grafting, because grafting means that you have to have a harvest site of some form. Increases the amount of time that we're going to be treating the patient, because we can't load these early and we can't load these immediately. There's additional cost to it, especially if you're going to be using artificial xenographic grafting materials. And sometimes it can reduce our success rate. And because of all these factors, I think that it means there's less patient acceptance, and it means that less patients are going to want to have implant treatment. So how do we go around this problem? Well, the coaxial implant has been developed, and it allows us to place the implant at an angle and yet still have a screw access hole. So let's have a look at some cases here. This is the case where we've got a central incisor that's a composite crown present, and this central incisor is failing because of caries that's going along the composite and the post that was placed. So in this case, we extract this tooth and immediately place our implant there. So in this case, I've done a small vestibular flap technique, and I've placed the coaxial implant. You can see the angle that I'm drilling. I'm actually drilling through an angle which is through the incisal edge of the tooth. But because it's a coaxial implant, I am now able to screw retain through the cingulum on the palatal side. And that's the tissue after it's healed. And you can see it's beautiful tissue, and it's well shaped from the temporary crown. And now we've fabricated our permanent crown, and that central incisor is done. And this was done back in February 2005. This is one of our earlier cases. As you can see there, that central incisor, cosmetically looks quite reasonable. And I saw this gentleman again. Oh, by the way, I've got an X-ray here. Notice the bone level around there. I've platform switched the implant, and the bone level is pretty much at the level of the platform of the implant. I've seen this gentleman since. This is the picture taken in October 2009. You can see the central incisor there. Again, still quite reasonable there. Gingival margin is good. A little bit of graying of the gingiva, but still a very, very good restoration. The other teeth have over-erupted a little bit and have darkened a little bit due to age. But when we look at a periapical here, again, the bone level is excellent. Okay, so a 2-implant case, exactly the same. 2 central incisors, 2 implants placed. And you can see the nice screw retain restoration through the cingulum. The individual single UCLA type crowns. And that's the lab work there and our final results. And again, because of the coaxial implant, we've got a very, very acceptable restoration, which is completely retrievable. And there's a periapical of those two implants there. Well, the premaxilla that we're talking about, the buccal concavity, extends further back and extends towards the premolar areas as well. Sometimes it even extends down to the first molar, but certainly premolars in the maxilla can have huge buccal concavities. So in the case like this, you can see that I've placed the coaxial implant here, and you can see that there's a little buccal fenestration there, very, very small. Now, if I had placed that implant, along the axis where I wanted to screw retain, there would be much more implant exposed. Because you can see here, we've got a very nice screw retained angulation there, but the implant is angled towards the buccal. Now, let's digress a little bit here, and let's talk about screw retention versus cement retain, in the sense that sometimes the bone just is at such an angle you cannot screw retain, even with a coaxial implant. So you might say to me, well, if that's the case, if the bone is at such a steep angle, why bother using a coaxial implant here? Well, let me tell you, most people would think that by using a custom abutment, you can get yourself out of trouble in most situations. And I can tell you now that that's not true. So if you have a look at this picture here, you might say, well, okay, that implant's at quite a large angle, and by using a UCLA type of abutment there, what we're able to achieve is a custom abutment, and by using that custom abutment, we can formulate our final restoration. But what we can't forget, of course, is that when we make a custom abutment, we have to have a UCLA type of cylinder, and also we can't forget the fact that there's an abutment screw there. And having an abutment screw there means that there's a screw head on the abutment screw. And when we compare that to the shape of our final abutment, you can see that screw head is actually sticking through the buccal side. And this is extremely difficult to try and resolve. And the reason is this: if you were to cut away that screw head, you're not going to be able to put it in through with a screwdriver. And once you cut away that screw head, it's very hard to actually remove that screw there. So this is a clinical case where I've stuffed up because I didn't have a coaxial implant. So a lateral incisor, okay, and when you look at the soft tissue, it's quite reasonable. Soft and hard tissue is adequate for reasonable restoration. However, when I finish this case, you can see how much recession I've had on the buccal gingiva of that lateral incisor. And the reason is I had placed it at too steep an angle. If I had used the coaxials, I would have been able to cement on still, but had a better aesthetic outcome. So if I had used the coaxials there, you can see the screw head would have been much, much more palatable. And so therefore, that would have saved my butt. Okay, so we've spoken about the premaxilla now. Let's speak about the maxillary sinus. And, even though the coaxial implant was originally developed for the premaxilla, we can actually use the same concept and place it elsewhere in the mouth. So let's talk about other places. So the maxillary sinus, as you know, is in the maxilla, of course. It has a soft membrane or lining in there called the Schneiderian membrane. It's quite often used, for resonating. So if you have sinusitis, of course, your voice or your tone is different. In some patients, the actual maxillary sinus is enlarged, Some people call it pneumatized, but that's just enlargement as far as I'm concerned, because it varies between people whether they have teeth or they don't have teeth in the posterior maxilla. So you can see here a case where we've got two very large maxillary sinuses. Posterior to that, of course, is your pterygoid plate of your sphenoid bone. And sometimes we need to graft these maxillary sinuses. In a case like this, we've got a upper premolar that's congenitally missing. And you can see on this picture, there's very little bone there to place the implant. This tooth was failing. And so in a case like this, we were forced to graft this case, to do a sinus lift. And here's the case here after we finish. And, you know, I'm not saying that we can avoid sinus lifts. We still have to sinus lift in a lot of cases. Even if we try, in a case like this where we've tried to angle the implant, we were still forced to do a sinus lift here. And sinus lifts are very, very successful. This is a consensus done in 1996 from the AO, and they found that there was something like 90% success rate on 3,000 implants. And that's not bad. However, you can't do sinus lifts in all cases. In a case like this where the sinus membrane, the Schneiderian membrane, have thickened, it means that there's some form of infection there and you can't graft these cases. So, why don't we lateral think? If we can't do sinus lift, is there another way? Is it possible to search and seek other bone that we can place our implants in? Do we make the patient fit the implant, or do we make the implant fit the patient? Well, luckily, we now have the coaxis implant, and so we can actually make the implant fit the patient. So, is grafting really necessary? Because we're talking about the maxillary sinus here. It's posterior maxilla. There's no need for us to have any cosmetic value in things. So, do we really want to graft the patient? And if you were the patient, would you really want to have grafting done? So, to that effect, what we can do is we can do other things. So we've spoken about the premaxilla, tilted implants. Other methods of treating a large maxillary sinus is with short implants. We can do tilted implants in the anterior wall of the maxillary sinus. We can do pterygoid implants. We can do zygomatic implants. So let's talk about short implants first. Well, short implants, of course, have been around for a long time, and short implants are very, very successful. So you can see here, this is just one of many papers that shows that short implants, less than or equal to 8.5 millimeter, have a success rate that's very, very high, okay, in the high 90s. So what are we looking at here? So in a case like this, we need to really search for the bone, and we can see two little peaks of bone there. And those two little peaks of bones are very, very small, 5.5 millimeter, 8 millimeter. And so in a case like this, we can just sneak in two very short implants there. And you can see, without grafting, I've been able to restore this case with two implants there. So, but what other things can we do? Well, we can look at tilted implants in the anterior wall of the maxillary sinus, and this is where coaxes have really made a difference in my practice. So you can look at a case like this where a patient is missing the premolars and one molar. So what do we do in a case like this? Should we do sinus lifts there? And Aparicio, in his study of tilted implants, he found that tilted implants have an extremely high success rate. In fact, 98.9%, which is comparable to axial implants, so straight implants, that is. So this is, again, just one of many studies that show that tilted implants are very, very successful. So let me show you that particular case, and I've put in place two implants, one in the premolar area, and I've placed a coaxis implant so it tilts the screw axis back towards the palatal. But the more posterior tooth there, you can see I've tilted the implant on the anterior wall of the maxillary sinus. So again, I've been able to utilize that bone there, because if I had placed that implant any further distal, I would be in the maxillary sinus there. So this is, again, one of our early cases, March 2005, when we finished the restoration. And that was her there after the restoration. So the premolar and that first molar there, you can see. And again, January 2010. Now this is what some 5 years later. You can see the bone has been exactly the same, hasn't changed its level, and the restoration still looks fantastic. Now, when we tilt implants in the anterior wall of the maxillary sinus, what we do need to know is that if we're going to place multiple implants, we may have to tilt other implants as well. So in a case like this, where we do have the maxillary sinus that's quite large, we've tilted the most distal implant, but the second last implant there, the one that's slightly more mesial, had to be tilted as well so that we gain enough bone. And that's easily done again with the coaxial implant, because we can get screw access with almost any tilted implant. So there's our case there. It's all finished without sinus lifting. Okay, so that's our final case. As you can see, radiographs, fantastic bone level, and we haven't had to do much grafting, and so therefore our case was finished within 4 months. Now, some of you might have seen this case here. This is a lady who came to see me because she had lost the premolar and molar there. And you can see there's a dip in the maxillary sinus just between where the two teeth ought to be. So in this case, what I did was I placed implants both in the anterior wall of the maxillary sinus and just posterior to that dip there. And you can see I've used 24-degree coaxial implants in this case, and see the angulation that the implants were placed. There's a very, very severe angle in order to avoid the maxillary sinus, and both implants were placed at huge angles. But when you look at the healing abutments there, the healing abutments are relatively parallel, and they'll look like you've actually placed the implant axially and without actually doing a sinus lift. So you can see there we've got the impression copings there. If the implants were not coaxial implants and we placed these implants at an angle, we wouldn't have been able to fit our impression copings in there because they would hit each other. So this is the case finished now. Again, you can see the dip in the maxillary sinus just between the two implants. And clinically, it looks perfectly acceptable with screw retained restorations. The patient had lost a second molar after a number of years, and this is what she looked like. Those two implants are still functioning very nicely. So let's look at another case. Again, exactly the same, except in this case, we found that the anterior site, we couldn't really tilt the implant very much, so we only had to tilt the implant in the posterior sites. And again, you can see after placing the implants, both of these implants look like they're fairly axial. So impression can be taken and our final restoration made. And you can see here the radiograph showing where the maxillary sinus is, and we've avoided maxillary sinus simply because we're thinking a little bit smarter. We're trying to do really nice dentistry without putting the patient through excessive number of procedures. Now, in the past, what we've done is we've actually done full arch cases using axial implants, and because we've used axial implants, these have to be cement retained. So in a case like this, as I said before, because there's cement retained, multiple implants, we had to mill these abutments. And we had to place the abutments in exactly the correct position. And because there are so many abutments involved, we've had to make the cement margin slightly supragingival or equigingival so that we can actually clean out all the cements in time. And to me, this is not an ideal restoration. So let me show you what I do these days. These days, I would, in a case like this, where she's going to lose all her maxillary teeth, an elderly lady who's about 65, she's a smoker, okay, so that we can't really do a lot of grafting on her. So we immediately extracted her remaining upper teeth, placed 4 implants, and these are all coaxial implants, made a temporary bridge for her, and that's her with a temporary bridge in place. And some 4 months later, you can see soft tissue has healed beautifully. All these implants can be screw retained, so we can go direct to fixture rather than having to use a secondary abutment. So unlike Palomalo, where he had placed angulated abutments on the distal, because we have the coaxial implants, we do not need that the angulated abutment. We can go direct to fixture. So you can see how well spread anterior-posterior these fixtures are. So mechanically, it's very favorable. And so we finished this case in June 2007. As you can see, a screw retain restoration on 4 implants. And the nice thing about this is that there was no grafting necessary. You can see that the implants have been tilted in the anterior wall of the sinus there. And if we had used axial implants, we would not have been able to use, we wouldn't have been able to get a impression coping into the distal implants there because of the angulation. But luckily, because of the coaxial implant, we can now use impression copings and access them quite easily. So I'd like to show you, of course, the periapicals. You can see bone levels are extremely good. Okay, these are all platform switch, so bone levels are excellent. And you might say, well, what's that sort of radiolucent area between the implant and the prosthesis? Well, that slightly less radiodense area is in fact a titanium ring, and that's from the passive abutments that Southern sells, and that's a totally different topic, but this abutment has revolutionized my practice, and I can make passive restorations at a fraction of what I used to pay for large screw retained prostheses. And look at the bone level in February 2010. You can see bone level again is excellent on all 4 implants. So let's look at this case here. This gentleman unfortunately has almost, it looks like he's got a tooth right in the middle of his face, the Cyclops type of appearance. But that's not what I want to talk about in this case. What I want to talk about is early loading or immediate loading. So when you look at a case like this, that's his OPG. That's where his maxillary sinus is. All these teeth are failing on the right-hand side of his mouth. And when you look at where the roots are, you can see that there is no bone apical to the roots. And so we wanted to immediately place the implant, or we wanted to early load. There's no way we could have placed axial implants here. So in this case, what I've done is I've still placed our 4 implants. But notice here what I've done is I've extracted the teeth and immediately placed the implant by placing the implants at a significant angle, crossing the interproximal bone between the sockets there. And so these implants are immediately loaded. And you can see our final results there, and the bone level, again, is extremely good. and we've been able to immediately load this situation here by placing an implant at an angle. So you can see here, this is the same gentleman, the most distal implant on his right. That's a coaxial implant, and that was placed immediately and loaded immediately as well. Okay, so here's the prosthesis, and that's the final case. And you can see here the OPG shows the angulation that the implant was placed, and no one would believe that the implant was actually placed immediately, even though there was nothing but root sockets just there. Okay. So pterygoid implants, you're going to be seeing, for those of you going to South America, we'll be seeing Dr. Stuart Graves. And Stuart, I spent, just a short few days speaking to him about his pterygoid implants, because he was one of the first people to write up pterygoid implants. And these implants, again, have been a very successful part of my practice. So the success rates are extremely high. Let's look at some of the success rates that are in the literature. 164 pterygoid implant, and there's a 96.3% survival rate. So these implants have been very, very successful. Now, what are we talking about when we're talking about pterygoid implants? Well, it sounds difficult, but in fact, it's not difficult at all, because what we're doing is we're going through the tuberosity of the maxilla, and we're ending up in the pterygoid plates of the sphenoid bone. So this is the type of angle that we're looking at. So we're actually avoiding the maxillary sinus and going into the dense bone that is the pterygoid plates of the sphenoid bone. So in a different depiction, you can see here, we've got our entry point in the maxillary tuberosity, and we've got an exit point in the pterygoid, in between the two pterygoid plates. Now, the muscles are only attached to the lateral pterygoid plates, whereas right in the middle between the two pterygoid plates is quite a safe zone. There's not a lot of vessels or nerves there or muscles, and so it's a very safe zone to use. And let's look at the view looking from behind. There's the pterygoid plates. You've got your pterygoid hamulus, the little notch or little hook-like bone on the bottom of the plates, and your exit point is up the top where the two plates converge together. And so let's show you some cases. And like I said, after Dr. Graves has shown me about on how to place these implants, they've been absolutely fantastic and they've saved me a lot of times. So in a case like this, we've got some missing teeth. You can see all these are screw retain restorations. And that's our final result. Now it looks like they were just normal axial implants. But when you look at it very carefully, you can see these are the periapicals. So the bone level is excellent. But when you look at OPG, you can see very clearly now the patient's left has a pterygoid implant. Okay, patient's right has tilted implant in the distal to avoid the sinus, but the left-hand side's a pterygoid implant, and that's been extremely successful. You can see that's the bone level there, and it quite clearly shows that that pterygoid implant is nicely in very good bone. So let's take this one step further. This is a middle-aged lady. She's in the late 40s, and she had severe periodontitis, and you can see she really needs a full clearance, and that's exactly what we did for her. So we extracted all her teeth, and when you look at the mandible, it's quite easy to restore with implants. But in the maxilla, what we need to look at is exactly where the bone is. And when you look closely at the maxilla, you might say to yourself, well, hang on, there's absolutely no bone there. This x-ray was taken about 2 months after the extraction. You can see how we're going to place implant. are we going to use a full denture? And at her age, she didn't want to have a full denture. She's never had a denture before. She's not happy with the full denture that I had made for her, so she wanted implants. So when you look at her clinical picture here, she's lost a lot of bone where she's had a lot of perio. The bone is very, very deficient. So we've been able to place 6 implants here. 2 implants in the pterygoid area, but 4 in the premaxilla. Now, you might say, well, hang on, that's a large space between where the premaxilla is and where the pterygoid implants are. Well, remember that the pterygoid implant is very, very distal, and when you place a bridge between those implants, the pterygoid implant acts like a class 3 lever. So in actual fact, it doesn't take as much load as you think. So there's our final case here. And because of the fact that the pictures are taken, at the time of issue, you can see that the gingiva is slightly blanched. But that's a fixed restoration on implants on a case where we wouldn't have thought implants were possible. So that's her there. And when you look at the OPG, you can see where the pterygoid implants are, okay, and you can see where the premaxillary implants are, and they're all coaxes implants. So because of the large maxillary sinus, we haven't been able to place implants where the sinus is, but we've placed implants everywhere else, and we've managed to restore the case without large grafts. So zygomatic implants, I don't really want to talk about this because I have had no experience here. Zygomatic implants, of course, are placed in the residual maxilla, posterior maxilla, and anchors into the zygomatic bone. And you can see sometimes it even goes very close to the orbit there. And this is the case by my friend Professor House. And zygomatic implants are very, very successful. In fact, so successful that that in this particular paper it said that after 2 to 5 years of function, none of the zygomatic implants were lost. But just a precaution for those of us who are not familiar with zygomatic implants, they're very long implants, and as I said, they go very close to the orbit. And in this case here, this is a case report of an implant actually gone through the cranium and into the brain, basically, because it's part of it is intracerebral, and this patient had obviously had some symptoms of chronic fatigue and severe headaches. So, to wrap up the maxilla, I'd like to just show you this particular case here. This is a really nice case to show what coaxes implants can do. So in a case like this, you can see that's where the bone is, and I've outlined where the bone is. So large maxillary sinus. We want 3 implants in there. So we want 3 implants in there. Traditionally, what we would do is we would place a sinus lift, so we can actually place those 3 implants there. In fact, the only implant that we could have placed without a sinus lift is probably the most mesial implant. However, if we wanted to think laterally, we wanted to be able to place implants so that we didn't have to do a graft. So you can see this is the result after I placed the implants, no grafting. So you look at the 3 implants and you might say, well, hey, they look like they're adequately spaced. They look like normal implants. Well, they are almost normal implants, but they're all placed at an angle. Okay. Now, I should have used a 24-degree coaxes implant in the most distal site, but these are all 12-degree implants. And I've twisted them a little bit so that one screw axis hole is towards a buccal and one towards a palatal. And when we look at the lab work there, that's our lab work with the porcelain on. And you can see some of the angulations that my technicians have made for me. You can see 2 screw access hole in the first molar. And that's our case there in the mouth, okay? So looking at that bridge there, it's a 4-unit bridge. The implants are well supported. And you can see here, that's the final case. And in the posterior maxilla, we don't have to worry about where the gingival margin is. But if you have a really close look at this new OPG, what we find is that here's a close-up of the OPG, and here is the bone where the maxillary sinus is. So the most anterior implant has been placed in the premaxilla. It's angulated so that it avoids the buccal concavity, and it's angulated towards the palatal. The middle implant has been placed on the anterior wall of the maxillary sinus and angulated so that we've got a proper screw access through the 6 there. And the very last implant on the 7 is a pterygoid implant. And if I had used a 24 degree, we would have got a screw access through the 7, but it didn't matter in this case because we could screw access through the buccal of the 6 there. So in this case, we've combined all those ideas, use coaxial implants, and we've been able to do this without grafting. Okay, so I just want to spend 1 or 2 minutes on the mandible, and then we'll finish up. In the mandible, of course, there is such a thing as a submandibular fossa, and we have to angle our implants so that we would go through the bone without penetrating that submandibular fossa. So in this case, a coaxial implant was placed, and you can see we get a nice screw access through the occlusal surface. Now, if we didn't use the coaxial implant and we wanted to have a straight implant, you might say, well, couldn't you have moved the implant more towards the buccal surface if you wanted to avoid a lingual concavity? And that would be absolutely true. But if you have a look at the buccal view of this particular implant, you can see that if we had moved the implant any more buccally, we would have had a lot more threads being exposed there. But in this case, because we've used the coaxial implant, we've avoided both the buccal deficiency and the lingual concavity because of the submandibular fossa. So submandibular fossa is something that increases in magnitude or size as you go towards the posterior part of the mandible. And in a case like this, what we've done is we've used normal straight implants on the 6, but in the 7 area, we've used coaxial implants because the lingual concavity was more pronounced there. So that's the angle of the 6s, and that's the angle of the 7s. So the implants are at different angles. But because of the coaxial implant, we've been able to turn that axis back towards the buccal so that when we make our final restoration, all the restoration are screw retained as you would normally expect. And that's it in the patient's mouth. So of course, the other thing that we can do with coaxial implant is, again, just like the maxillary, we can do the all-in-4 type of situation where we tilt the implant, and in the mandible, we have to tilt the implant to avoid the mental foramen there. And so, again, you can see a nice anterior-posterior spread so that we've got as much support as we can for the posterior segment of the prosthesis. Screw retained, and that is the final result in the patient's mouth. So, to summarize, the coaxial implant has provided screw access, so it allows me to easily restore my cases with good aesthetics. It allows me to avoid anatomical limitations. We can avoid vital structures such as the maxillary sinus and mandibular canal without grafting. And we don't need grafting nearly as much anymore. We still need grafting in some situations, but most of the cases we don't have to graft anymore. In fact, I hardly ever graft these days because now that I have these coaxial implants. The only time I really have to graft is in certain situations in the posterior maxilla, and also for cosmetic cases in the anterior maxilla. Because we didn't have to graft, we reduced the amount of time that's needed for treatment. We can provide better angulations for impression copings, especially if these implants are tilted in the posterior part of the mouth. We don't need to have custom abutments, and we don't need for secondary abutments to help change the angulation. And so, therefore, we can reduce the amount of clinical time that we use, and the laboratories are finding it very easy to provide restorations for my cases. And because the laboratory don't have to do as much, because I don't have to buy secondary abutments, I don't have to have customized components, overall, it reduces cost for me, and I can pass that cost on to my patients. So it's better accepted by my patients. So in my clinic, I've placed approximately 1,100 implants. That's 1,100 coaxis implants over a 6-year period. I've had 2 loss of integrations, and both of them are immediate placement, so immediate extraction, immediate placement. And also, I've had 1 failure because these are tapered implants, and because I've cranked them so high in terms of my insertion torque that I've stripped the hex of the coaxis implant. So overall, a very, very successful implant design, and I hope that helps you in understanding a little bit more about the implant. So thank you very much.